Welcome to everybody. I'm Paolo Pelosi, head of the Department of Anesthesia and Critical Care at San Martino Policlinico Hospital. I will discuss today how to use PEEP in prone position. No conflict of interest specifically related to this lecture. This is a summary slide showing the level of PEEP applied in the prone studies as compared to the theoretical higher PEEP that should have been applied if following the actual recommendation for more severe ARDS patients. As you can see here, the PEEP set in the prone study was much lower as compared to the higher level of PEEP that has been recommended in more severe ARDS. So most of studies with low PEEP were used in prone position. There was a paucity of data with high PEEP in prone. There is no standardized PEEP setting in prone position. So we have to discuss if it's better to use a strategy in supine position with higher PEEP level, or prone position with lower PEEP, or prone position with higher PEEP. This is a CT scan in supine position with densities more located in the dependent part of the lung. When the patient is prone, we observed a sort of reverse of these densities and back again on the dorsal zone when the patient is repositioned supine. When we look at the lung inflation in normal, blue lines, and ARDS patients, red lines, we found a vertical gradient in lung inflation from non-dependent to the dependent lung regions, while in prone position, a more homogeneous distribution of inflation. On the other side, if we look at the regional perfusion, as you can see here, in supine position, perfusion is mainly distributed in the dependent lung regions compared to the non-dependent ones, while in prone position, the perfusion remains in the non-dependent part. These changes in aeration and perfusion are related to the changes in the regional pleural pressure from dependent to non-dependent lung regions. As you can see here, in supine position, pleural pressure is more negative in non-dependent compared to the dependent part and much more homogeneous in prone position. And this is even more effective in patients or animals with edema or ARDS, when the gradient from non-dependent to the dependent part is much higher, with minus 3 centimeter water in non-dependent lung region and plus 3 centimeter water in supine position in the dependent lung regions, while more homogeneous distribution of pleural pressure in prone. So if you summarize the modeling of aeration and pleural pressure from supine to prone, in prone position, we observe a recruitment of atelectatic lung regions in dependent position in supine and in non-dependent position in prone, and a more homogeneous distribution of transpulmonary pressure, which is associated with a more homogeneous distribution of ventilation, while perfusion remains in the dorsal lung region, so improving the ventilation perfusion mismatch. Another positive effect of prone position is to reduce the lung stress strain in RDS. Here is shown the elastance of the lung in supine position and in prone position, and when patients are repositioned as supine, in black and red. And you can see here that the stress is much lower in prone position as compared to supine position, being the elastance lower and the compliance higher. And this is associated with changes in the elastance and compliance of the chest wall. So we proposed a model in which in supine position, we have a higher distribution of ventilation towards non-dependent part and less distribution in the dependent part of the lung. While when we prone the patients, we have a reduction in the stiffness of the sternal part of the lung, and this is associated with more distribution of ventilation towards the abdomen. Sorry, there was a problem.
Andate piano.
Cioè, can restart from this point? Si è bloccato a questa slide. Da qui. Mi fa conto anche qui alla rovescia? Posso andare. Prone position. Allora. Prone position reduces lung stress and strain ARDS. As shown here, the elastance of the lung in prone position is lower as compared to supine position, black in supine and red in prone, and this is mainly due to changes in the elastance of the chest wall. We developed a model suggesting that in supine position, the ventilation is more distributed in the non-dependent part of the lung and partially distributed towards the abdomen. When we prone the patients, we have a reduction in the compliance of the sternal part of the respiratory system, with a reduction in chest wall compliance and increasing the elastance of the chest wall, and this promotes a redistribution of ventilation towards the abdomen. And we found that the chest wall elastance and chest wall compliance was associated with the improvement in oxygenation. Higher the compliance, higher the improvement in oxygenation, as well as the changes in compliance by itself from supine to prone. Prone position also minimizes ventilator-induced lung injury, and you see here the lungs of animals ventilated in supine, in upper panels, and in prone position. So you see here that the wet to dry ratio was much higher in supine position as compared to prone position, and this effect was mainly in the dependent part of the lung. Also, the histologic score was much better in prone as compared to supine, and this effect was more evident in the dependent part of the lung. So proning may allow to reduce the level of PEEP and FiO2. We have different types of RDS, the so-called lobar RDS, where we have more aeration in non-dependent as compared to the dependent part of the lung, and diffuse RDS, patchy or more uniform alteration of the disease. And studies showed that in lobar RDS as compared to diffuse RDS, prone position was associated with more recruitment and more decrease in overinflation. So in presence of focal loss of aeration, lobar RDS, when we increase the PEEP, we have a minimal improvement in oxygenation. On the other side, prone position is associated with a major improvement in oxygenation, which is not affected by PEEP in prone position. In presence of patchy or diffuse loss of aeration, as called diffuse RDS, we can observe a major increase in oxygenation by increasing the level of PEEP, and also by prone position by itself. So if we compare the high recruitable RDS patient, as you can see here, the amount of recruitable and non-recruitable lungs, so the opening and closing, may be minimized, especially when we increase the level of PEEP, but even more when we further increase the level of PEEP in prone position. And also the amount of overinflation is minimized mainly by when we use prone position and higher level of PEEP, while it is increased when you use higher PEEP in supine position. In presence of poor recruitable RDS, we observe no major changes in opening and closing of the atelectatic alveoli by increasing the level of PEEP in prone or supine, but the amount of overdistension is higher in supine at 15 centimeters of water, and also in prone position at 15 centimeters of water. So the application of higher PEEP in prone appears to be associated with less opening and closing and less hyperinflation when is applied in high recruitable patients as compared to poor recruitable RDS patients. Some studies investigated the role of individualized PEEP in prone and supine position. In this study was compared the PEEP set according to the low PO2 FO2 table and the PEEP set according to the esophageal pressure at end expiration, plus 3 centimeters of water. The level of PEEP by using the low PO2 table were similar in supine and prone position at 10 centimeters of water. And as you can see here, the prone position was associated with better oxygenation and better elastance. When PEEP was set according to the esophageal pressure and end expiration, there were no difference between supine and prone, and PEEP was a bit higher as compared to the low PEEP PFO2 table. And again, there was an improvement in oxygenation and improvement in elastance. So does not seem any major difference if we set PEEP individually by using low PEEP PFO2 table or esophageal pressure at end expiration. We did a recent study in experimental model looking at the effects of PEEP set according to the low PO2 table and PEEP set according to the lowest driving transpulmonary pressure. We found, again, similar to patients, that using the low PO2 table, the PEEP was similar in supine and prone, and by using the lowest driving pressure, the PEEP was a little bit higher, but not much as compared to the low PO2 table. Interestingly, when we look at the PO2 table, we found that there was a major improvement in oxygenation. While setting the PEEP according to the lowest driving pressure, there were a higher oxygenation in supine, but this was not associated with a further improvement in oxygenation when the animal were prone. On the other side, the transpulmonary driving pressure was reduced by using both the low PO2 table or the lowest driving pressure. So the improvement in oxygenation was higher in prone position when PEEP was set according to the low PO2 table, but not when set according to the driving transpulmonary pressure. When we look at the lung strain, as you can see here, there was an increase in the lung strain, especially in supine position in the vertebral areas as compared to the sternal areas, and much more homogeneous and less in prone position. And the same was observed when PEEP was set according to the driving transpulmonary pressure. Similar data when we look at the tidal recruitment, which was of course affected by supine or prone position, but there were no major difference when PEEP was set according to the PO2 table or the driving transpulmonary pressure. And the same for the VAQ ratio, which was of course reversed when the animal was set in prone position, but substantially the improvement in oxygenation was better when PEEP was set by using individualized PEEP by PO2 table as compared to the best driving transpulmonary pressure. So the oxygenation response to prone position depends on the PEEP titration technique. There was no improvement in oxygenation in prone when using driving transpulmonary pressure to set PEEP, and prone position could enhance lung protection independent from PEEP titration technique and from the oxygenation response. Some studies investigated individualized PEEP titration in prone with high 20 centimeters of water or low intra-abdominal pressure. Here you can see the driving pressure at different PEEP level in supine and prone position at low or higher intra-abdominal pressure. And as you can see here, substantially there were difference between high and low intra-abdominal pressure, but there were no difference between prone and supine position. So prone and PEEP independently improved lung compliance. Intra-abdominal hypertension increased the PEEP needed for the best lung compliance, and best PEEP was not significantly different between prone and supine. So to conclude, PEEP and prone position in ARDS. Prone position improve oxygenation and minimize lung injury in experimental models. Strategies to improve survival in ARDS are prone with low moderate PEEP. This is my best choice in setting of ventilation in severe ARDS. Supine and high PEEP, but probably not higher than 15 centimeters of water, and combination of prone and high PEEP. Prone position improve oxygenation and minimize overdistension, mainly in focal lobar ARDS. Oxygenation response to prone depends on PEEP titration technique, as I show you, and intra-abdominal pressure does not affect response to PEEP in prone position. So my strategy to ventilate RDS patients: close the lungs and keep them resting to minimize ventilator-induced lung injury. Look for minimal PEEP for minimal saturation, 88 to 92%, or PO2 55 to 80 millimeter mercury, which might be associated with minimal right ventricular impairment. Prone the patient to open up the lung and keep the lung open at minimal RE pressure and PEEP, and thus no increased injurious static strain, which is induced by higher level of PEEP. Thank you very much.